So I want you to picture a hospital at night. But instead of the quiet hum of medical machinery, the air is just thick with smoke.
Oh, wow. Yeah, that's a terrifying image.
It really is. You're looking at Mongbalu Hospital in the Democratic Republic of Congo, right near the eastern border with Uganda, and the facility is under attack.
Right.
Young men from the surrounding community are like storming the grounds. They're burning down the triage tents set up by Doctors Without Borders, and they're demanding the hospital hand over the bodies of their deceased relatives.
And, I mean, the terrifying reality of that specific scene is that those bodies are highly infectious. They died of Ebola.
Exactly.
So the medical staff are forced to evacuate. Patients are fleeing the fire, just vanishing back into the local community. And a lethal virus is essentially turned loose.
Right, which is exactly why we are jumping straight into our stack of sources today. We need to figure out why the global health response to pandemics is, well, fundamentally breaking down.
Yeah, it's a massive failure point.
We have on-the-ground news reports detailing this exact DRC outbreak, alongside some really dense theoretical frameworks on healthcare resource allocation. Plus, a detailed blueprint for a radical new technology called the Dr. Maya AI and the Prima kiosk.
That's quite a stack.
It is. And our mission today for this deep dive is to unpack the central paradox that this crisis exposes. The possibility that our current medical protocols, like the very act of seeking care, might be actively increasing infection rates.
Yeah, and to understand the technology proposing to fix this, we really have to deeply analyze the failure playing out right now in the Ituri province of the DRC.
Right.
Our sources point out that this is actually the 17th Ebola outbreak in the country, but this specific isolated community hasn't faced it before.
And that lack of prior exposure creates a massive, almost impenetrable wall of denial, doesn't it?
Oh, absolutely.
I mean, the population is already dealing with regional conflict and displacement. Suddenly, a terrifying disease arrives, and because they have no historical context for it, people simply don't believe the disease is real.
Yeah, they view it as a rumor, or even, some sort of government conspiracy.
Right. And when you have that level of deep-seated fear and distrust, the standard international playbook just shatters completely.
Well, it does. And now, the source material gets highly critical here. And just as a quick disclaimer to you listening, we're acting purely as messengers for this research. We're not taking political sides here.
Right. We're just laying out what's in the text.
Exactly. But the authors explicitly align with the decision by former U.S. President Donald Trump to defund the World Health Organization.
Oh, wow. Okay.
Yeah, they argue the WHO has essentially become a white elephant staffed by academicians who lack the practical, on-the-ground crisis skills needed to halt an outbreak of this speed.
I mean, the critique in these papers goes way beyond just bureaucratic bloat, though.
Yeah.
They point to a fatal flaw in the actual medical protocols issued by the WHO and the CDC.
Yeah, the core advice.
Right. The standard universal advice during an outbreak is that if you develop symptoms, you should travel to a primary care clinic or an Ebola treatment center.
Which, sounds completely logical, right? If you're sick, you go to the doctor.
I thought so too, until I really looked at the logistics of that journey through the lens of a highly contagious pathogen.
It's a nightmare scenario.
It is. Okay, let's unpack this. You have an infected person in a rural village. They get on public transport. They travel for hours, literally shedding the virus the entire time.
Yeah.
Then they sit in a crowded triage waiting room, which basically acts as a giant mixing bowl for viruses.
The sources actually refer to this as the transmission trap.
Transmission trap, right.
Because the authorities themselves admit they are having immense difficulty tracing the contacts of these traveling patients.
Of course they are.
And they also can't effectively track the infected individuals who just stay home and are treated by traditional healers.
Yeah, it's a massive blind spot.
And for the ones who do make it to the clinic, they are often admitted to wards right alongside other infected patients or even deceased patients. This leads to massive cross-contamination that ends up infecting the healthcare workers trying to save them.
Wow. So if the very protocol of bringing a sick person to a central hospital is what's killing the community, it completely upends how we think about medical intervention.
It changes everything.
But we can't just abandon patients in their villages, right?
No, definitely not. And that is the core problem the theoretical frameworks in our stack are trying to solve. They argue we have to completely rethink the concept of the medical gatekeeper.
Go ahead.
Currently, the physical hospital and the triage doctor, they act as the gatekeepers to care. The sources introduce a shift using artificial intelligence, specifically a concept called allocation away AI, to basically move that gatekeeper.
Wait, so instead of the AI just being like A weatherman predicting a 90% chance of rain, which is just risk prediction, like you probably have Ebola. How does allocation-aware actually work?
That is the perfect distinction. Traditional healthcare AI operates exactly like that weatherman. It gives a statistical probability of a disease. But one of our academic sources points out a really harsh reality. In a crisis, healthcare is not a prediction problem. It is a scarcity-constrained stochastic allocation problem.
Okay, I'm going to need you to translate that out of academic speak for me.
Yeah, fair enough. Think of it like this. You have a finite number of doctors, beds, and time.
Right.
If you have 100 sick people and only 10 beds, simply predicting that 50 people have Ebola doesn't tell you who actually gets the bed.
Ah, I see.
Right. If you give a bed to someone who is unfortunately going to pass away regardless of intervention, or someone who is going to recover perfectly fine on their own at home.
The marginal utility is zero.
Exactly. The marginal utility of that bed is zero. So allocation-aware AI calculates the actual utility of the intervention. It mathematically identifies the specific patient whose trajectory is changed solely by receiving that scarce resource.
Oh, wow. So it's less like a weatherman predicting the storm and more like an air traffic controller looking at a severely limited number of runways.
Yes.
And they are routing the planes so they don't crash into each other or overwhelm the tarmac.
That is exactly how the math shifts. What's fascinating here is that when an infection is highly contagious, bringing everyone to the central gatekeeper crashes the system.
You overwhelm the physical space.
Right. And you infect the air traffic controller, so to speak.
Right, the doctors.
Yeah. By accurately estimating the utility of a hospital visit for each specific patient, the AI can reroute the flow of patients before they ever travel.
Before they get on that bus.
Exactly. The simulation data and the research shows that this allocation-aware approach increases realized utility, meaning actual survival rates and efficient use of resources, by 18 to 25% over traditional risk threshold policies.
That's a massive jump. And moving the gatekeeper from the hospital directly into the patient's own community is where the physical technology actually comes in, right?
Yes, exactly.
The blueprints in our stack detail the PRIMA kiosk. PRIMA stands for Personal, Responsive, Empowering Medical Assistance.
It's quite the acronym.
It is, and I want to build a visual of this for you listening. Imagine a standalone, rugged, solar-powered terminal. It looks a bit like a modern public telephone booth, but it's dedicated entirely to healthcare triage.
And the interface on it is a fascinating study in accessible design.
Yeah.
Yeah, it doesn't rely on complex menus or text. It uses voice-first interaction and visual icons.
Oh, that's smart.
Right, you can walk up to it and simply speak your symptoms in your local dialect. This immediately breaks down the literacy barrier, making it instantly accessible to the roughly 600 million people in rural India and other developing regions who are, well, effectively locked out of smartphone-based text health apps.
Now, I really struggled with the technical logistics of this when I was reading the source. Well, the blueprint says it has dual SIM 4G and 5G, but it also heavily emphasizes that it works entirely offline.
Right.
So how does an advanced AI triage patients in a rural DRC village if a cell tower goes down or just simply doesn't exist?
The architecture is actually quite clever. The core logic of the AI, which is a specialized LLM, is compressed and runs locally on the edge device.
Meaning the kiosk itself.
Exactly. It doesn't need to ping a cloud server in California to analyze your symptoms.
Oh, wow.
Yeah, and when it does need to sync data back to the health ministry or update its models, it uses intermittent connectivity.
What does that mean practically?
Well, if there's no broadband, it can compress the anonymized epidemiological data into tiny alphanumeric strings, and it sends them via basic 2G SMS payloads whenever it catches a fleeting signal.
That is incredibly resilient.
Yeah. Or a local health worker can physically sync the data via Bluetooth when they visit the village.
Okay, so inside that kiosk is the brain driving all of this, Dr. Maya GPT. And the sources emphasize that Dr. Maya isn't just crunching raw statistical algorithms.
No, it's much more nuanced.
They trained it on the clinical intuition of a doctor with 50 years of experience. It listens to the unique combination of symptoms and acts as an intelligent triage system.
Right. It replicates the clinical reasoning of a seasoned junior doctor right at the point of first contact.
And the output of that reasoning is incredibly simple. It uses a 4-color triage system to direct the patient.
Yes. Red means emergency. The AI has calculated that your utility for a hospital bed is absolute. High-priority life-saving intervention is needed, so go to the hospital immediately.
Okay. And then green means moderate symptoms. You don't need the emergency room, but you should call on their triage line, kind of like NHS 111, to book an appointment.
Right.
Yellow is for mild symptoms. The advice there is to speak to a local chemist or pharmacist for over-the-counter advice.
But the final color is where this entire system truly attempts to break the chain of a pandemic.
Here's where it gets really interesting.
Yeah. Blue stands for infectious risk, and the instructed action for a blue code is not to seek out a doctor. The action is to isolate.
Think about your own life for a second. If an ATM-style machine at your local grocery store scanned you, flashed a blue screen, and told you to drop everything, cancel your plans, and lock yourself in your house for 14 days because you're an infectious risk,
It's a huge ask.
would you do it? It completely challenges our modern instinct. We are wired to push through illness, to take a pill and go to work, or to rush to an emergency room the absolute second we feel a fever.
It is deeply counterintuitive, but if we go back to the miner in the Ituri province of the DRC, we see the power of that counterintuitive action.
Right.
If that miner feels unwell, walks up to a Prima kiosk in his village, speaks his symptoms, and gets a blue screen, the system identifies him as a potential vector.
So he doesn't get on the bus.
Exactly. He doesn't sit in the clinic waiting room. He doesn't infect the triage nurse. The source data suggests that this immediate point of origin isolation can stop 30 to 50% of transmission instantly.
Wow, you literally stopped the fire from ever starting. But we have to tackle the massive sociological hurdle the sources raise here. We started this deep dive talking about a hospital being burned down because the community didn't trust the medical establishment.
Right. The trust deficit is real.
If they don't trust the WHO and they think Ebola is a conspiracy, why on earth would they trust a glowing blue screen on a machine?
Well, the designers of the Prima system openly acknowledge that technology alone cannot solve a trust deficit. The kiosks are structurally designed to be community-owned.
Meaning what exactly?
They aren't just dropped in by foreign governments or international NGOs. They are placed in local temples, mosques, schools, and markets.
And they're operated by locals. The blueprints detail a role called Maya advocates.
Yes.
These might be local mothers, street vendors, or community elders who are trained and actually get paid a micro wage to help run the kiosks and assist users.
It completely turns public health into a trusted, grassroots micro-business.
Right. When your neighbor, who you've known for 20 years, is guiding you to use the machine in your own local dialect, the fear and suspicion drop dramatically.
Exactly. But if we connect this to the bigger picture, even if we solve the trust issue, the sources point out a brutal economic reality.
Yeah, this part is heavy.
Telling a daily wage laborer in rural India or the DRC to isolate is essentially telling them to starve.
Right. If they don't work that day, their family literally doesn't eat that night. How does a color-coded screen actually work if the people using it cannot afford to stay home?
The creators of Dr. Maya recognize you just cannot prescribe isolation without systemic support. The sources argue that the blue code must be linked directly to social safety nets.
Right.
It cannot just be medical advice. It has to be an economic trigger.
So the blue screen is essentially talking to the welfare state.
In a fully implemented system, yes. If a vulnerable worker gets a blue code, that signal verified by the kiosks should immediately trigger government food delivery and wage compensation for that specific individual.
Wow.
Because without economic support, isolation isn't a medical protocol. It is a privilege that the poor simply cannot afford.
That reframes public health entirely. It forces us to look at a pandemic not just as a biological event, but as a socioeconomic one.
Absolutely.
And speaking of shifting our perspective, our sources zoom out from the Ebola crisis to explore how this exact same kiosk technology is critical for an entirely different but equally terrifying threat.
The post-antibiotic era.
Right. Driven by antimicrobial resistance, or AMR.
This is where the decentralized triage of the Prima kiosk becomes absolutely vital for the daily survival of modern medicine.
Yeah.
The statistics on AMR in the source material are chilling. Currently, 42 out of 100 people with AMR infections cannot be cured.
That is almost half.
Yeah, we are rapidly running out of effective antibiotics because the bacteria are mutating faster than we can invent new drugs.
I want to connect this back to our miner in the DRC. Let's say there is no Ebola outbreak.
Yeah.
He just has a regular mild viral flu. He follows the traditional protocol and travels to the primary care clinic.
Right, and in that scenario, he encounters what the sources call the managerial strangulation of healthcare.
Managerial strangulation.
Yeah, the clinic is overwhelmed. The doctor might have only 3 minutes to evaluate him. They don't have the time or the resources to run a full blood panel to confirm it's just a virus.
Right.
So, out of an abundance of caution, or frankly simply to get the patient out the door to see the next person, the doctor prescribes a broad-spectrum antibiotic.
Right, just in case.
Exactly. The problem is antibiotics do absolutely nothing for a viral infection.
Nothing at all.
But what they do is wipe out the susceptible bacteria in that minor's body, leaving behind only the naturally resistant mutant strains.
Oh, wow. So you've essentially created a training camp for superbugs.
Exactly. When people rush to the doctor for every minor viral fever, they are exposed to hospital-acquired superbugs, and they drive this massive overprescription crisis.
This is where the yellow and green codes on the Prima kiosk become a massive global shield.
Right.
If that minor goes to the kiosk instead of the clinic, the Dr. Maya AI, using its 50 years of clinical intuition, recognizes the symptom pattern as a simple viral fever.
Yeah.
It issues a yellow code. It tells him to go to the local pharmacist for some over-the-counter fever reducers.
He never sees the overworked doctor. He never demands an antibiotic.
Exactly. The kiosk formalizes the role of the local pharmacist, giving them the AI guardrails to treat mild symptoms safely.
Which protects the patient from the hospital environment, and crucially, it protects the global antibiotic supply chain from being wasted.
It's filtering the noise out of the system so the doctors can focus on the red codes.
Yes.
But the Prima network does something even more powerful on a macro level, acting as a global, decentralized nervous system.
This is my favorite part of the research.
Right. Right now, global health acts like a massive dinosaur. If it gets bitten on the tail by a new virus, the local clinic has to notice. They have to send paper records to a regional office.
Who sends it to the National Health Ministry?
Exactly. Who eventually alerts the brain at the WHO headquarters. By the time the brain realizes the tail is bitten, the infection has spread everywhere.
Yeah, it's way too slow. The Prima network turns the community into an octopus, where each arm has its own localized brain that can react instantly.
I love that analogy.
Because every kiosk is tracking these anonymized symptoms in real time, the system spots anomalies before a human ever could.
Right.
Imagine a new respiratory virus emerges. If thousands of people in a specific neighborhood all suddenly start flagging blue with similar symptoms on their local kiosks, the AI flags the cluster immediately.
That's incredible.
The sources note this kind of localized monitoring can identify an outbreak 7 to 14 days before the first spike in hospital admissions even occurs.
Think about what that means for you living in your own community. Imagine knowing that a localized outbreak is happening in your specific zip code in real time because the kiosks are picking it up.
It changes everything.
You aren't waiting for a delayed government press release or for the hospitals to start overflowing before it makes the evening news. It completely restores autonomy and responsibility to the individual.
Right.
You have the tools to know and act yourself safely without adding to the burden on the healthcare system.
It's the ultimate shift from a reactive healthcare system that waits for us to break down and show up at the emergency room to a proactive defense network that keeps the infection from ever leaving the neighborhood.
We started this deep dive looking at a burning hospital in the DRC. That tragedy shows us the devastating consequences of centralizing care during a highly contagious outbreak when community trust is broken.
Yeah.
Forcing symptomatic patients to travel to primary care or Ebola centers isn't just inefficient. The evidence suggests it actively fuels the transmission trap.
It does.
But by utilizing Dr. Maya AI-powered Prima kiosks as community-level gatekeepers, we completely flip the model. We can identify infections locally, advise isolation immediately with the necessary economic support, protect our healthcare workers from cross-contamination, and potentially stop pandemics at their absolute source.
It intercepts the crisis at the village level, utilizing advanced allocation-aware AI that requires no internet connection and speaks the local language.
It's a remarkable blueprint for the future of global health.
Yeah.
But it leaves us with a final lingering question to mull over.
Always a catch.
Always. We are talking about a massive shift in power and information. If global health shifts away from top-down international organizations like the WHO, who currently collect, manage, and distribute all epidemiological data to a decentralized network where individual communities generate, own, and act on their own real-time health intelligence, how will traditional governments react?
That is the big unknown.
When citizens of a small town know about a viral outbreak weeks before the Ministry of Health does, will those central authorities support these community gatekeepers, or will they see them as a threat to their monopoly on public health information? It's a tension that might define the next era of our survival.